So today let's talk briefly about aortic ultrasound and how and why we do it. As I'm sure you've heard about 100 times before, I'm Sarah Pasodi, and I'm the one running this curriculum for you all. So there's two main reasons to do point-of-care aortic ultrasound. First and foremost, it is a screening test, albeit a very low sensitivity screening test for a potentially catastrophic diagnosis, namely aortic dissection. So the point that I'm trying to make here is that if you have an ill patient and you can suspect that they might have a dissection, while you're trying to get either a consultant to the bedside or you're trying to get them down to definitive imaging, which is the CT angiogram, ultrasound can be a helpful and potentially very specific, but not at all sensitive test to help rule in the diagnosis. It is not by any means sensitive enough for you to even think about ruling it out. What happens in aortic dissection, as a brief reminder, is that you have a small defect within the wall of the thoracic aorta or the abdominal aorta. And what happens is, because of how high pressure the system is, blood tends to pump into that area and it starts to shunt straight down into the false lumen, creating this huge big tract. You can see right here, this is the false tract of the aorta that's built right here. And then this is the real abdominal aorta, thoracic aorta and abdominal aorta splitting into the iliacs. So this is a nice normal, this is a nice very clear image of what that would look like. The mortality and morbidity of this is high, so catching it early is helpful. So we will talk about how to do it, but I will again stress that this is a specific, not a sensitive test. So normal ultrasound does not by any means rule this out. You need to do more testing if you're at all worried. The diagnosis that it is far more helpful for is actually for AAA. So abdominal aortic aneurysms come in two major flavors: fusiform and saccular. Fusiform aneurysms are these nice symmetrical, bilaterally visible dilations in both walls, and is what I'm trying to say, and it's a symmetric dilation. And the reason that's important is because, as you'll see, sometimes it's hard to sort of track every small centimeter of the aorta and to catch both walls all the time. But if this is symmetrical and it's a relatively large area that tends to get a fusiform aneurysm, you'll find it more often than you would find a small saccular aneurysm that just comes off of the one wall. So it's much more likely that you'd miss this. Now, luckily, saccular aneurysms are very uncommon, but that being said, for fusiform aneurysms, we can easily find these on ultrasound most of the time. Saccular aneurysms are much harder to rule out. So if your probability is high, you may need more imaging there as well. Okay. Now let's talk about how to do it.
Alright, so we're going to talk briefly about how to do an actual aortic ultrasound. So this is the high fidelity mannequin you guys are going to be using. So first and foremost, probe marker will go to patient right as always to start off. The goal is you're going to start with the probe right underneath the xiphoid process. And I'll leave anatomy on the screen as well. So you can see liver on the right. That's what liver looks like on ultrasound, that mixed echogenicity stuff there. You'll come over to the midline, and then you're just going to start sliding slowly inferior. So now, as soon as you slide a little bit inferior, you'll start to see the spine. The spine being that structure all the way bottom at the end. You can see the spine on the anatomy screen as well. You'll see that you see the spine, you look right above it, and you see the aorta. The aorta is this structure right here that we're waving the mouse over. And then you're just going to track the aorta down. Now, when you see something like this, that's bowel gas. On a regular patient, the trick is you just sort of wait here and you add pressure until it goes away. The mannequins aren't as kind, so you'll just need to move the probe over a little bit, find that view again by angling backwards and then track it down. So now you can see branches of the aorta coming off right there, and you just slowly keep tracking it down. And you track it all the way down until you start to see it split. Right about here, now you can see it's splitting into the two iliacs right there. And we'll track it back up. So now you can see external iliacs there, coming back together, descending abdominal aorta here. Now the trick is you want to measure these in multiple spots, one in each location for proximal, mid, and distal. The aorta should be no more than 3 centimeters wide. Once you've made sure that the aorta is not 3 centimeters wide, you'd measure the iliacs. It should be no more than 1.5 centimeters. And if you are done with all of them, that looks good. The last view to get is a long axis view. Probe marker towards the head, you come right back to where you had a short axis view of the aorta, and then you track it this way by fanning and rotating very slightly until you see a pulsatile structure with numerous things coming off of it. And this is another view that helps you. Now the reason this is important is because if we look at aortic pathology, you'd end up seeing and you'll end up seeing the abnormalities in one of those views most of the time. Now the thing to remember is that when you're looking for an abdominal aortic aneurysm, you can have it in multiple locations. You can have it suprarenal, infrarenal. You can have what are called small saccular aneurysms, which are just little outpouchings that are very hard to see on point of care ultrasound. Or you can have fusiform aneurysms that are a lot simpler to find. So here again, we're doing the same thing, tracking it down, and right there you're starting to see it get real big. So you measure this right here from an anterior to posterior approach. And you'd see that that's over 4.5 centimeters. And as we discussed, 3 centimeters is the upper limit of normal. And then you track that down. Now remember here we've lost sight of it, but if you weren't sure, you could come over and see this in long axis and see that huge big outpouching there. That would be a fusiform aneurysm.
All right. So if you have any questions or concerns, please don't hesitate to email me at this email. The goal will be to go through each of these steps in practice on standardized patients and on the simulators. I'm looking forward to seeing you. Thanks.